Hi, everyone. I'm Dr. Laura James. Most of you know me, at least most of you, I think, should know me, although I'm seeing some people pipe in whom I've not met before. So that's always a wonderful thing. All of these crowdcast events that I've been doing for the last few months, I have been focusing on breast cancer. This talk, however, is going to be a little broader focused. I realize that most of my friends, we're all in our late 40s and early 50s, and most of my friends are starting to go through menopause. And since I have been working with women, both in the women's health context and in the women's cancers context, for almost 20 years, I thought I would share some of my expertise regarding dealing with menopause in a natural way for my friends and also for my patients. So I already have one question regarding answering some questions about how menopause might be different or might be treated differently for women who have undergone breast cancer treatment. I'll address that a little bit at the end because I really wanted this talk to be more focused for all women. I also don't have a PowerPoint presentation for this particular talk, and I'm hoping that this can be a little bit more interactive. You're welcome to post notes which go to the whole group. You can ask questions. There's a different way to do that, and unfortunately, my screen is very different from your screen. So hopefully, you guys can figure out how to ask a question. I see Debbie from Charlottesville, Virginia, is saying thank you for having this talk. I feel like there isn't a lot of open conversation about menopause and one's experience during this phase of life. Good. I'm glad you're happy about it, Debbie. I'm going to try and cover all the bases and tell you pretty much everything I know about menopause. So if you have questions, go ahead and ask them. You can ask them privately and I can answer them for you. You can also post them where everybody's going to see your questions. If you would like, I can actually make you live and you can ask the question live and participate. So let me know when you ask the question if you would also like to be part of this presentation. This is being recorded. All of these crowdcast events are recorded and then they're replayed, so they're accessible in perpetuity through my website, but also on my channel here on Crowdcast. So welcome Hillary from Louisiana. Welcome Stella, and now I remember who you are, Stella. Welcome Stella from Chicago. Debbie, hello. There are a bunch of other people here who have not said hello, and I'm still waiting on a bunch of other folks. But hopefully they'll join the event as we go along. And like I said, there is the replay option available. So let's talk about menopause. I think Debbie's right. There are lots of aspects of menopause that just don't get talked about openly. And we're all at different stages of the game when it comes to when does menopause actually occur. The average age of menopause for American women is 55. And so that's the average age. It could be anywhere around there. Granted, my patient population is a little bit skewed because I see a lot of women with cancer. So often because of their chemotherapy treatments, they might go into menopause in their 30s. But in general, for my non-cancer patients, I've seen menopause occur as early as 38 and as late as 62. So 55 seems like a pretty good median for what we expect to start undergoing the change. There's a definition really of menopause that most women don't really understand necessarily. Menopause is actually one day. Menopause is the 366th day after which you have not had a menstrual cycle for 12 months. So you're perimenopausal potentially for a long time. Perimenopause can take years, really. And then you're menopausal for one day. And then after that, you're postmenopausal. So generally, women do not know when exactly their day of menopause is unless they're keeping very, very good track. And not everybody has time for that, right? And the symptoms, the perimenopausal symptoms and the postmenopausal symptoms are pretty much the same, although they tend to intensify once you're postmenopausal. So when you're perimenopausal, you can start with night sweats, you can start getting hot flashes, maybe some emotional irritability, maybe some insomnia. But often you'll keep having your periods, they'll be irregular. Maybe you'll go from a 28-day cycle to a 36-day cycle to a 48-day cycle, and sort of anything in between. Maybe you start having periods every 2 weeks, and they're very light and there's just a lot of spotting. So what happens with menopause is you have two primary reproductive hormones, estrogen and progesterone. And there are, lots of sort of different chemicals involved with both of those, 3 different estrogens, lots of metabolites. At any rate, progesterone starts to go down first. And when progesterone starts waning, when a woman's in her 40s, generally, that's when we start seeing perimenopausal symptoms. That's when periods become irregular and maybe you have spotting, or maybe you start having regular but really, really heavy periods. And so progesterone starts going down. It's when estrogen starts going down or when estrogen starts to fluctuate that you really start getting the classic menopausal symptoms like hot flashes. Night sweats generally can occur when progesterone is going down, but hot flashes usually not until your estrogen really starts going down too. So I see we almost have everybody here. So welcome all of you who've just joined. So perimenopause, like I said, can take a really long time and have a whole bunch of symptoms attached. Menopause is one day, day 366, and then after that, you're postmenopausal. So what are some of the really important things about that time frame? One of the most important things about that time frame is that women lose the most bone density in the first 5 years after menopause. So if you're sort of keeping track and you have an idea if you're perimenopausal, where menopause might have occurred, and if you're postmenopausal, you're going to start losing bone density because your bones need estrogen to stay dense. And so if you know already that you have low bone density, or if your mother had osteoporosis and your grandmother before her, or there's a bone density issue in your family that's known already, or you're at risk for osteoporosis because you've been on thyroid medication or steroids for a long time, or you're of Northern European descent and you have blonde hair and blue eyes like me, you're at higher risk for osteoporosis. So in those first 5 years after menopause occurs, that's when women lose the most bone. So if you are perimenopausal at this point, or you know that you haven't had a period for 12 months, so you're menopausal, maybe ask your primary care physician if you can have a DEXA scan. A DEXA is a bone density scan that will give you a baseline of where you're at for your bone density. Because frankly, menopause is not going to kill you, but falling and breaking an osteoporotic hip could. Actually, falling and breaking a hip is the number 3 cause of death for American women, because women fall, they break their hips, and then they don't get up again. And so you don't want that to happen to you. We have peak bone density at age 35, and then it just starts going down until you hit menopause, and then it rapidly goes down. So if you're in that perimenopausal phase, or you're just newly menopausal, ask your primary care physician to get a DEXA scan. That's a long range thought for living in menopause. And, face it, our life expectancy at this point in this state of the universe in the United States is, 75 and above. So you could feasibly be menopausal for 25, 30 years. And over that whole time frame, you'd be losing bone, right? So, but bone isn't something you can feel. Bone isn't something that necessarily, well, you can feel it, but I mean, bone loss isn't something that you can feel. The things you can feel are hot flashes, night sweats, insomnia, vaginal dryness, low libido, all of those things. So those are the things that I really want to talk with you about today, and I want to give you some strategies for managing. One thing there are two things I don't want to forget to mention before I get into some of those therapies. One is, here's the question. Let's see. Wait, let me answer Debbie's question here. Her question is, after 5 years post-menopause, does the loss stop, or is the loss slower and more gradual? Is there a way to stop the loss or slow it down? Yeah, so after that first 5 years after menopause, where you have the most bone loss, it does start to slow down and it becomes more gradual. So in terms of really slowing down that bone loss, the best therapy for bone loss really is estrogen replacement therapy, but not everybody's a candidate for that, and not everybody wants to do that. Making sure that you have the best nutrients on board, not only calcium, but vitamin D, magnesium, vitamin K, boron. There's a whole list of vitamins and minerals that are essential for bone health. Having those on board, making sure that you're eating high calcium foods also. And that's not just dairy. Actually, a cup of bok choy provides more calcium in milligrams than a cup of yogurt. So a cup of bok choy gives you 320 milligrams of calcium, and a cup of yogurt is like 290 or something. So making sure that you have really good high calcium foods in your diet, because you absorb more calcium through your food than you do from supplements. But supplements can also be really helpful. That's why I like for women to get a baseline bone density, a baseline DEXA, so that we really know what we're dealing with for the long term. But it does slow down. It's just those first 5 years where it can be really, really rapid. Couple other things I want to mention. Sometimes I get the question of, well, how do I know for sure that I'm in menopause? And sometimes patients, doctors will, like primary care doctors, will measure LH and FSH, as well as estradiol, progesterone, maybe testosterone. There are a couple of lab values that can be measured. FH is FSH and LH. I said that wrong. FSH is follicle stimulating hormone and LH is luteinizing hormone. And they are the hormones that play a role in how an egg, when it's released from your ovaries, matures and then either becomes fertilized or turns into the corpus luteum if it's not fertilized, and then dissolves. And so if you have blood drawn, they'd be looking at FSH and LH. And if those values are high, you're most likely in menopause. But really, menopause occurs after 365 days of no period. And it has to do with how many eggs you have in your ovaries. Everybody has a finite number of eggs in your ovaries. You might have 200 eggs in one ovary and 300 eggs in the other ovary, and they're popping out every month, or they're popping out in multiples if you have polycystic ovarian disease or something like that. But that's it. When you're done, you're done. And then you become menopausal. So you can look at the lab values of FSH and LH, but really it's tracking that menstrual cycle. So those are the ways to really tell where you're at. The other question I get is about birth control during menopause. Until you are 100% sure that you have not had a period for 12 months, you can still get pregnant. And that would really suck if you're 54 and you've already had your family, right? I mean, the chances of you becoming pregnant are much, much lower, but it could still happen. And so, really, the best kind of birth control would be an IUD. And IUDs are much, much better now than they were when we were kids. They don't cause the kind of, uterine perforation that the old style IUDs caused. There are a couple different kinds. There's a Mirena, Kylena, and Skyla, and all of those are progesterone releasing IUDs, and they're in different doses. And so my general opinion about any kind of exogenous hormone use, meaning you're using a hormone from the outside, not a hormone that your body has made, any kind of exogenous hormone use, I prefer for women to have the lowest dose possible. Now, the Mirena is the highest dose, and often it's used if a woman has really heavy uterine bleeding problems, because it emits this little bit of progestin, which is a synthetic progesterone. And it can slow down that heavy bleeding as well as provide contraception. But the Kylena, I have to look because I get these names all wrong. Kylena and Skyla are much lower dose progestin IUDs and are just used for contraception. So if you had a period 6 months ago and you haven't had one since, you still need to worry about contraception. And I think an IUD is a good choice, or a low dose birth control pill. That's another good option. I mean, you can obviously go the barrier route, but that can be messy, or that can be just a pain in the butt. So I think that an IUD or a low dose birth control pill can really be a good choice. But you still need it until you're pretty darn sure that you're in menopause. So any other questions so far about those things before we talk about symptoms? I see we've got about 3/4 of the people that I was expecting. Any questions you have, you can type in the chat bar and I'm happy to answer them. Okay, no questions. Well, if you think of something, just let me know. So let's talk about hot flashes. Hot flashes are probably the most disrupting aspect of menopause for most women. You can have hot flashes all day long. You can have hot flashes all night long. You can have one hot flash during the day. You can have, it can fluctuate. Your hot flashes can be worse when you're under stress. They can be worse when you drink alcohol. There can definitely be triggers, and sometimes those triggers are individual, but generally things like alcohol, caffeine, chocolate, those are things that can bring on a hot flash for many people. Spicy foods, things that might be kind of heating, can cause hot flashes. And you want to take your clothes off. It is just suffocating. So there are lots of different ways to manage hot flashes. So for my women who have not had any kind of breast cancer, there are more options. Obviously, for women who've had breast cancer, there are maybe fewer options, but that would also be something for you to talk about with your physician if you're in that camp. Let's talk about herbal options first, and then we'll talk about hormone replacement options. So I brought some show and tell for you guys. And I'm not trying to do product placement. I do not get anything from these companies. I just am showing you what I have in my clinic and what I think is a good product. So, but these are all things that I recommend for my patients, and everything's widely available. So, hello from Bellevue. Hello, Laura from Bellevue. All right. So this is generally where I start. This is black cohosh. Probably you've heard of this. Black cohosh is a tried and true method of managing hot flashes. I usually start here, and about 50% of the women that I treat get benefit from black cohosh. Black cohosh does not work in a hormonal way. It is safe for women to use, even women who have had breast cancer. So black cohosh is non-hormonal, and it can regulate hot flashes predominantly. That's what I use it for. I haven't seen it be incredibly effective for other symptoms of menopause. But I start with black cohosh. So this brand, Vitanica, is a really good brand. It was developed by one of my colleagues who is a women's health specialist down in Portland, Oregon. So in general, the Vitanica brand, I think, is a trusted brand, and it's really widely available. You can find this in most natural foods markets or a place like Pharmaca. You can certainly find it online. But this particular product is standardized. All right, so here's the other thing about menopause. As you start losing your goddamn eyesight, you have like glasses in every single pocket. Black cohosh, Cimicifuga racemosa. This is standardized to the root and rhizome extract to contain the triterpene glycosides, 40 milligrams. So I generally start patients with at least one capsule, if not more like two, and going up to three. Generally, if you get to 3 capsules of this and it's not controlling your hot flashes, then we need to go to something else. But I always like to start here because it does work for about 50% of the population. And I'm saying hi to Adrienne Berg out there in North Carolina. Hi, Adrienne. Let's see. List of other things to use. Some of these things are easily available, some of them not so much. I will tell you, I am working with a supplement company to try and put together a really awesome formula, particularly for my women who've had breast cancer and can't do anything hormonal, but it will have black cohosh in it. Debbie is saying, do you recommend capsules versus tincture or tea? I do recommend capsules. I am a naturopathic physician, but I'm a naturopathic oncologist. And generally, the patient population I'm working with needs natural compounds in therapeutic doses. So I tend to dose things pretty high. And often I find that tinctures and teas aren't quite effective enough. So I generally use capsules. That also just seems to be the population of people that I work with, many of whom are like, what the heck's a tincture? So I don't always recommend tinctures. Other easy things to find around where you live that you could try would be vitamin E. I always recommend a mixed tocopherol vitamin E. You can go up as high as 1,800 IUs of a mixed tocopherol vitamin E to manage hot flashes. That's very effective. You can divide the doses with that, take some in the morning and some at night. However, vitamin E is a fat-soluble nutrient, and so it's going to stay in your system longer. So any of the fat-soluble nutrients, vitamin A, D, E, and K, you don't have to take all the time. You know, you can take sort of a bigger dose at one point in time. So up to 1,800 IUs of a mixed tocopherol vitamin E is fine. Women often find alleviation of their hot flashes at 800 to 1,200 IUs of vitamin E. That's a relatively easy thing. There are various soy preparations that can be useful for hot flashes as well. And the meta-analyses of soy over time in relation to breast cancer is that soy is actually breast protective. Soy is a phytoestrogen, so it is a plant form of estrogen that does sit in the estrogen receptor of the breast. And I'm going to draw you a little picture here just so you can understand this, because we are going to be talking about estrogen, and hopefully you'll be able to see this okay. But here's your boob, right? There's your boob. and your boob has receptors on it. That's an estrogen receptor. And so for any of you who've done biochemistry, receptors are this lock and key model. So a molecule comes in and sits in this receptor and then can stimulate the tissue that the receptor is attached to. So if this is an estrogen receptor, what is it going to receive? It's going to receive estrogen. And then the estrogen is going to cause a lot of stimulation of breast tissue, right? So if you have an estrogen receptor here, and what sits in here is similar, but maybe, looks a little different on the other side. Here, let's say that's a soy molecule. It sits in the estrogen receptor. It fits the same way because it's a phytoestrogen, but it doesn't cause nearly as much stimulation as that breast tissue because it's a lot weaker than estrogen. But what is it doing? It's actually taking up space in that receptor so that the estrogen itself doesn't sit in there and cause that big level of stimulation. Does that make sense? So soy can be breast protective because it's taking up space in those estrogen receptors. So even for my women who've had breast cancer, I say soy is totally fine for them to have in their diet. That's dietary soy. I don't recommend soy ipraflavone or isoflavone capsules, which are what would be used in a menopausal setting. There are lots of different preparations that use ipraflavones, isoflavones to give that phytoestrogenic action for managing hot flashes and other menopausal symptoms. I don't recommend those for my breast cancer patients. But for your average patient, for your average woman, a soy compound can be breast protective and also help with hot flashes. Flax falls into that same category. Flax does have, like flax seed, has a very mild phytoestrogenic quality. I haven't found flax seed to be that effective in managing hot flashes, but as part of a regular diet, it can also take up space and be breast protective. Flax seeds, you can eat them whole, but they generally will go through your system pretty quickly. Keep fresh flax seeds in your freezer and grind them in either a coffee grinder or a spice grinder right before you're going to eat them. You can put them on morning oatmeal or bake with them or do something like that. So you can get some good phytoestrogen protection from flax in your diet, but I'm not so sure it's great for managing hot flashes. There are a couple other compounds that I think are appropriate and sometimes effective for healthy women. That would be maca, M-A-C-A. Maca actually raises estrogen levels. You can find that in, again, various over-the-counter hot flash management products. And again, the only real product I'm showing you is this one because I carry it in my clinic and I recommend it all the time. I don't carry any products that have maca in them because mostly my patients do have a history of cancer and predominantly breast. So, but you can find products with maca, and maca can be really effective, not only for managing hot flashes, but also for increasing libido. I know that there's one product out there called Feminescence that has maca in it that women just love, if you can take that one. So there's also a product out there called Estrovera. And if you want more details about all these, just send me an email and I'll try and remember the brand names of these. But there's a product called Estrovera that has a Siberian rhubarb in it that activates one of the two estradiol receptors. There's a estradiol alpha and an estradiol beta, and the Siberian rhubarb acts at the estradiol beta site, and some think that it's okay to use for women who've had breast cancer. I don't. But for women who are not at risk or haven't had breast cancer, then the Estrovera can be a really helpful thing. I've got a couple of questions here. Let me just see. What's the daily dose of maca powder? Good question, Laura from Bellevue. I'm going to have to look that one up and get back to you. I don't use it very often because of my patient population. Other things that can be very effective, dong quai, which is popular compound in a lot of Chinese medicines. That tends to be more of what we call an adaptogen. So an herbal adaptogen is something that if you have too much of something in your system, it'll bring it down. If you have too little, it'll bring it up. And there are some herbs that really act in this balancing way, this adaptogenic way, and dong quai is one of those. Red clover is another herb that can have some positive benefit in the menopausal world. I tend to use it more as one of the lymphatic drainage herbs for some of my patients. So I don't recommend that super heavily, but you might find it in a menopausal preparation. And my other two go-tos for women who can't do anything that is going to stimulate estrogen production are hesperidin methylchalcone. Say that 10 times fast. So hesperidin methylchalcone and gamma oryzanol. So I'll tell you about those two. Hesperidin methylchalcone is, it comes from the inner rind of citrus. So like if you have an orange and you peel the orange off and you've got that pithy bit on the inside, that's where they harvest the hesperidin methylchalcone from. And there's some limited data, but data nonetheless, that supports its use in managing hot flashes. You can find hesperidin methylchalcone in an encapsulated form, and that can be very effective. The other thing that can be effective is gamma oryzanol. Now, gamma oryzanol comes from rice bran oil. I have found gamma oryzanol to be extremely effective. However, I am not finding it as a standalone product anymore. The company that made it as just straight gamma oryzanol stopped making it about 10 years ago, and I haven't found it since. But I have seen it in menopausal formulas. And again, these are non-hormonal options for managing hot flashes. Sometimes they can also manage night sweats, but in general, it's managing hot flashes. And hot flashes, while they're pesky during the day and require that you wear layers of clothes, at night is when I really find patients have the biggest problems, because if you're waking up multiple times at night with hot flashes, then you're not going to sleep well. And sleep is really important. In fact, sleep should be like the number one thing you're going for. So if we can get your hot flashes under control, hopefully your sleep is going to be a lot better. The other things that you can do for sleep, and we're going to get back to hot flashes and night sweats, but the other things that you can do for sleep are to make sure that your bed breathes. Standard beds are made out of synthetic materials, and synthetic materials trap heat. And so if you're having hot flashes where you're generating heat, or you're sleeping with a partner who's a hot box under the same covers and you've got synthetic covers, that's just going to make everything more uncomfortable for you. So you can take a page out of the European book, which is the two of you sleep with an individual duvet cover or some kind of individual cover. And, you can cuddle if you want, or you can go your separate ways and sleep in your own, almost like sleeping bag, right? Or go sleep in another bed. Because again, if you're going to cuddle when you want, you're doing that when you're awake. And we're working full time. We've got families. We've got all sorts of stuff going on. Sleep is really important. There is no shame in going to sleep in the guest room if that allows you to have good quality sleep. Let me just check and see. I've got a couple other questions here. One more. Do you know if hesperidin is similar to using bergamot? That's an interesting question. Bergamot is not something that I generally think of for hot flashes. Again, I'm going to have to look that one up. And that question comes from the same person. So I'm just going to have to get back to you with the answers to all of your questions. So I've mentioned black cohosh, flax, soy, hesperidin methyl chalcone, gamma oryzanol, maca, dong quai, red clover. There's also Vitex angus castus, another herb used really heavily in women's health in tincture form, capsule form, tea form. Generally, that's a regulating form for regulating menstrual cycle, tonifying the uterus, that kind of thing. So depending on where you are in the sort of trajectory of perimenopause into menopause, there might be a place for Vitex. So let's talk about hormone replacement. So obviously for women who have had cancer, a hormone sensitive cancer, the use of any kind of topical hormone is going to be discouraged. Vaginal hormone use is different, and I'm going to talk about that as well. But topical hormones, there are lots of different choices and used in different ways. When a woman is perimenopausal and night sweats are sort of the beginning of the perimenopausal experience, often a topical progesterone cream is what is going to be recommended. Progesterone is bioidentical progesterone. That is what our own bodies make. So bioidentical hormones are either the same, chemical structure to the endogenous hormones or just a slightly altered structure. And so bioidentical hormones are differentiated from synthetic hormones. Synthetic hormones are made in the laboratory. You've heard of conjugated equine estrogens, Premarin, that comes from horse urine. That is not human estrogen, right? So when I talk about estrogen, estradiol particularly, estriol, which is another type of estrogen, but weaker than estradiol, and progesterone, I'm talking about what your body already makes and what you can find in a bioidentical preparation. So bioidentical hormones, some of those are prepared commercially, pharmaceutically. You can get them with a prescription. And some of them are created in compounding pharmacies. Compounding pharmacies are those that actually make whatever the product is that your doctor is prescribing for you. And what's nice about compounded pharmacy products is that they're really tailored to you. So if you need 13 milligrams of something, the compounding pharmacist can make it that way. Whereas the pharmaceutically produced products are going to be, you got your 10s, you got your 20s, you got your 50s, and, there's like nothing in between. So the compounded stuff can be really useful if you're trying to fine tune what you might need. So there are topical hormone preparations, progesterone cream. There are also estrogen creams. There are testosterone creams. These can be used on the skin. They can also be used on the labia. And there are some providers in this community, I practice mostly in Washington State, who prescribe bioidentical hormone creams to manage menopausal symptoms that are all applied on the labia of the vagina. Frankly, I think that's really messy and a pain in the butt. So I don't advocate those. Some people are fine with it, but I'm not a big fan of creams. Progesterone cream used for night sweats and maybe also for hot flashes often is rubbed on the thin skin of the forearm. You change forearms. You can rub it on the inside of your thighs. You can put it on your labia if you want. But that can be effective. I like better, though, from the compounding pharmacy that I use here in Washington. They make a progesterone oil. And so they're able to concentrate the bioidentical progesterone into an oil base. And then women can just drop dose the oil onto their thin-skinned areas, and it dissolves into the skin really nicely and really quickly. Because the base of something like a progesterone cream, like a standard progesterone cream, it's like white, it's goopy, right? And you're rubbing it in and you're rubbing it in and you're trying to get it on both forearms, and it like can get transferred to your cat. It can get transferred to your husband or your partner. You have to be kind of careful with that. Do I have an over-the-counter recommendation for progesterone? There are a couple different brands. I believe Vitanica makes an over-the-counter progesterone brand. If not Vitanica, her sister company, Bezwecken, makes a good one. There is no topical progesterone oil that is commercially available that I'm aware of. All that I'm aware of is that I can get it from the compounding pharmacy for my patients. So if you're interested in that and you're not in Washington, you might try and see if there's a compounding pharmacy in your area, and if your gynecologist or your primary care doctor would be able to prescribe something like that for you if that's appropriate. So progesterone can be in the creams, it can be in the topical oil, it can also be oral. And oral progesterone is pharmaceutically available. So that's a really simple prescription called Prometrium. Prometrium only comes in 100s and 200s and I think 400 milligram capsules. So again, there's not a whole lot of wiggle room in there. Compounded progesterone can be just about anything you want. But the advantage of oral progesterone is, number one, consistency. Because as you can imagine, especially if you're using a progesterone cream and it's like goopy and you don't know like how much is actually getting in there, you could be getting very inconsistent dosing. But if you're taking a capsule, it's going to be very consistent dosing. And what's nice about the oral progesterone is that it actually acts a little bit like a sedative. So it can help you sleep at night. And it also acts a little bit like an anxiolytic. So it can help bring your anxiety level down a little bit. So like 100 milligrams of Prometrium at night can actually kind of kill like 3 birds with 1 stone. Night sweats, potentially hot flashes. It's not always enough for hot flashes. Irritability and insomnia. So Laura from Bellevue says, I love my 100 milligram progesterone. Yeah, I mean, progesterone can be incredibly life-saving and give you the sleep you've been missing, tone your mood down a little bit, and start to manage some of the side effects or some of the effects of menopause. So that's oral progesterone. Let's talk about estrogen a little bit. So there are basically 3 estrogens that are endogenous to the body. E1, E2, and E3. E1 is estrone. We generally don't prescribe that one. E2 is estradiol. Estradiol is the most active form of estrogen in your body. Estriol is E3, and it's only a quarter as strong as the estradiol. Estriol can be used in various preparations to help manage hot flashes, other menopausal symptoms, and vaginal dryness. In fact, sometimes I'll prescribe an estriol suppository that's used vaginally to help with vaginal dryness. Estriol is one of the hormones that is high when you're pregnant. And it's, sort of a mellow estrogen. There's also a compounded formula called Biest, which is 20% estradiol and 80% estriol, and that can be in various forms. I often see it prescribed as an oral capsule for women who are dealing with hot flashes and other menopausal symptoms. The downside of oral estrogens is that it increases your clotting risk. And that is one of the biggest downsides of using estrogen products at all, is that oral estrogen can increase clotting. The birth control pill can increase clotting. Um, it is not an issue. Clotting is not an issue with topical estrogens. So here's an example of a topical estrogen. I really like prescribing this for my patients. This is the generic of something called the Vivel Dot. And this is a patch. So I'm going to show you what this looks like. And Hillary, I will get to your question in just a second. This is, I don't know if you guys can see this. Can you see it? It's this tiny little patch. And in that little patch, so it's sticky. And in this little patch is 0.0375 milligrams of estradiol. So straight up estradiol. And that will control your hot flashes, control your night sweats, control your mood, and also help to increase your bone density. So going back to what I said at the beginning about bone density and losing the most bone in the first 5 years after menopause, estrogen does maintain bone density, and it doesn't take very much. Let me quickly answer Hillary's question. Can you take progesterone after breast cancer or estrogen? It depends on the type of breast cancer that you've had. If you've had an estrogen sensitive breast cancer, no, you cannot use topicals or orals, but I do feel fine recommending vaginal estrogens, which I'm going to talk about next. And that's the same for progesterone, because we think at this point that progesterone is more of an issue in the hormone sensitive breast cancers than estrogen. Let me just give an aside to this along these lines. Using hormone replacement therapy does not cause breast cancer. If there is already a breast cancer there, it can be fuel for those cells, but it does not cause a de novo breast cancer. It takes at least 1 million cells to be detected as any kind of problem in the breast. And 1 million cells is about smaller than the tip of my pinky finger. So you have to accumulate a lot of malignant cells for anything to be seen on mammogram, for sure. And so, if you are predisposed, if you already have a breast cancer, the beginning of breast cancer, beginning of DCIS, ductal carcinoma in situ, taking hormone replacement could put fuel on the fire. My policy for women who've had an estrogen sensitive breast cancer is the only hormones I'm going to let them use are going to be vaginal, because vaginally you don't absorb the hormones systemically. It remains local absorption. The patch will provide systemic absorption. This estradiol, I'm going to be very specific. This estradiol, the strongest of the estrogens, is going to go everywhere in the body, and it's going to address all the body's tissues. It's going to help your skin. It's going to help your bones. It's going to help, your thinking. It's going to deal with your hot flashes and your night sweats, all of those things. And so, however, this patch doesn't always solve the vaginal dryness problem. And vaginal dryness can be really uncomfortable. It can make sexual intercourse really uncomfortable, and it can contribute, the lack of estrogen in your system can contribute to urinary problems. So the bladder actually has estrogen receptors all over the main muscle, the trigone. And so when your estrogen levels start to go down, that means your bladder isn't getting estrogen feeding that muscle. And so the muscle of the bladder then can start getting weaker and not hold on to your urine as well. And then you get leakage, you get urinary incontinence. And, if you've given birth to 3 babies and you've had all that kind of, pelvic trauma on top of it, then you probably have urinary incontinence by now. Also, without the estrogen in the vaginal tissue, and it providing the estrogen vaginally is enough to provide it to the bladder. The bladder is close enough. The health of the urethra, where we get urinary tract infections because of the way bacteria just kind of lives in there. Having some kind of vaginal estrogen preparation helps to mitigate the frequency with which you might be accumulating bacteria. Also, having a vaginal estrogen preparation can keep the pH of the vagina within normal range. And the pH is important because different bacteria grow at different pHs. So if your vagina becomes more acidic, you might have too much, actually, yeast doesn't grow in an acidic environment. Generally, it becomes more alkaline. And so you can get an increase of yeast infections. You can get an increase of something called BV, or bacterial vaginosis. And it's really just because you've lost all that estrogen from the vaginal tissue and the pH changes. And then those bugs just have an environment where they like to grow. So I have a couple questions here. Let me try and answer Hillary's question first. The thing I've never understood, if we are only raising the estrogen and or progesterone to normal premenopausal levels, then how is that bad? So I am not a practitioner who tries to raise hormone levels to premenopausal levels. That is more of an anti-aging strategy employed by particular providers who are interested in anti-aging. That is not my intent. My intent is to provide comfort, to eliminate some of the symptoms of menopause, to improve quality of life. And in the case of like bone density, to preserve bone density. And I'm always trying to do these things with the minimum amount of intervention required. That's part of naturopathic philosophy too, is use the minimum amounts required to achieve the goal that you want. Using bioidentical hormones to get somebody back to how they felt when they were 22, that's not my gig. I don't think that's safe. I don't think that's necessary. Another question, how long would someone use hormone replacement therapy if you stop using HRT? Are all the symptoms going to come back? Good question. The symptoms can return. The thing is, everybody's menopause experience is different. And so, Debbie, your menopause experience might take 5 years. Laura, your menopause experience might take 10, who knows, right? And when your estrogen levels stop fluctuating, that's when your symptoms will go away. And they either stop fluctuating when you give yourself something like estrogen, estradiol, right? Because you're stabilizing in your system a level of estradiol, or there's nothing left. And so there's nothing for your body to react to. So at some point in time, yes, you are going to experience the symptoms of menopause, and you'll just have to decide you're going to get through them. I tend to go by a woman's age and other sort of, we call them in medicine, comorbidities. What are the other issues that a patient is dealing with, and how do we prioritize those? And everybody's menopause experience is different. So I have some women who just sail through menopause and don't really need a whole lot of anything. And then I have women who are so uncomfortable. You'll be across the table from them, and every 5 minutes they turn bright red, like, I'm Mr. Heat Miser, and their hair's on fire, right? And so everybody is a little bit different. But for hormone replacement therapy for my healthy women, I generally like to keep them on it, into their 60s. Around 65 is when I start having the conversation of, maybe you don't need this anymore. I have had a few patients in my career who've been over 70 and they're like, damn it, I'm not giving this stuff up. And, those are slightly different conversations. I've noticed that for primary care doctors, at least in this community, women are being recommended to be on hormone replacement for very, very short periods of time. But then again, most conventional primary care providers are not as well versed in the bioidentical forms of hormone replacement than they are in the synthetic forms. So let's talk about vaginal health. So let's talk about vaginal health a little bit. I have a couple of things to kind of share with you regarding vaginal health. And again, there are many, many reasons to maintain your vaginal health in menopause because of that dryness that can occur. So since we're talking about hormone replacement therapy, this is my favorite tool. This is called an S-string. It is impregnated with estradiol, and it's springy. So it's like a diaphragm, but obviously it doesn't have the barrier on it like a diaphragm would. And this can be inserted into the vaginal vault, and then it pops up like over the cervix like that, and it lives there for 90 days. And it emits a tiny amount of estradiol every day for 90 days. You can take it, you can have intercourse with this in. You can take it out if it's uncomfortable for you or your partner, and then you just rinse it in the sink and then put it back in when you're done. I love these because it provides consistent estradiol support to the vaginal tissue. I use these in my patients who have had hormonal breast cancer. I use these in as many women as will accept them because I think they're great. They're not messy. You can put it in and forget about it, but make sure that you write down on your calendar when you're supposed to take it out and change it. The thing that really sucks about these, like all other women's healthcare issues, is that they're bloody expensive and not all insurance will cover it. So it depends on your insurance plan. The market rate for these things is like $450. Can you believe it? $450. You can get them from Canada for about $110. So if you have a provider who's willing to send your prescription to Canada, you can get it in Canada. Or you might be lucky and your insurance will cover the whole thing, but you're going to have to check the formulary of your insurance plan. But I love the S-string, and it's not a birth control ring. There is something called a NuvaRing that's kind of similar, but that's birth control. There is also a ring called a Fem ring. Question from Debbie, how difficult are they to take out? No more difficult than a diaphragm. You basically, if it's up over the cervix like this, you basically have to sort of insert your finger into the vagina and then just pop it out. I think it's harder for women to get in there because you have to squeeze it, and these can be slippery little suckers in the bathroom. So, but pulling it out, you're gonna pull it out like that, and then it comes right out, and then you just throw it in the trash. But I love these. I think these are great. There is another one called a Fem ring, and a Fem ring actually is a much higher dose of estradiol that does have systemic effect. And so if you want to kind of cover all your bases, a Fem ring might be a good option because it's a ring that goes in over the cervix, but it has so much estradiol in it that it provides systemic effect. And so you can hit all the bases that you would want to hit with something like this. Personally, these are the things that I use. I love this. I think this is great. And I love these patches because this is a twice weekly packet or twice weekly patch. They have a good adhesive. The adhesive doesn't come off in the shower or even a hot tub or even swimming. I used to swim a lot, and they don't come off. There are lots of different patch forms that you can find pharmaceutically. There are some patches that are just a whole week. These are twice a week. Different people have different experiences though. So sometimes you just need to kind of experiment. Non-hormonal options, there are lots of them. This is one that I really like. It's called Triple Goddess Rose Oil. This really is just for moisturizing the vaginal tissue, and you can use it with intercourse. It has a huge number of things in it. But a bunch of different oils. Let me just see here. Hazelnut oil, damask rose oil, natural vitamin E. This stuff smells really good, and it's available. It's pretty widely available. You know, you can get it off the internet. It has a nice feel. Again, it's something that needs to be applied on a regular basis. There are also various vaginal moisturizers that you can get at the drugstore. Most of them are water-based. Some of them are, I think they're all water-based just for vaginal moisture. I've had some patients who've had to use those regularly because they have all sorts of urinary issues, and just wiping after urination is painful because of the amount of dryness. And so that's a case where you want to have a lot of moisture on board. But this is really nice for intercourse, and as you know, you can use it as a daily moisturizer. It has a nice feel. This also is a relatively new product that I carry in my clinic. It is available online. It's called Vag Renew. And this is actually a really, really nice product and has a little bit more durability in terms of maintaining the moisture of the vagina than this does. This is kind of like you use it and then it kind of wears off relatively quickly. This can last a little bit longer. And it has some herbs, some natural compounds, and then some other stuff in it. So it's not necessarily the purest, but it's not horrible either. But it has soy isoflavones, black cohosh, and vitamin E in it. And my patients who are using this really like this product as well. That's Vag Renew. You can also just go with good old coconut oil. And I loved it when I found this at Trader Joe's, because get this, these are individual travel packs. So if you're traveling while you're menopausal and you're traveling with someone that you want to have sex with, here's your coconut oil. Trader Joe's has figured out that there are a lot of us who are menopausal who need coconut oil in little packages. So you can find this in your local Trader Joe's. Love that. Other estrogen-based vaginal things, there's the Vagifem, which comes as, and this is a prescription, Vagifem comes as a cream. It also comes as a tablet suppository. So it's like a long blue applicator. They come preloaded, and it's a tiny little tablet that melts into the body after it's inserted. That kind of vaginal suppository, and I mentioned earlier an estriol suppository, which the compounding pharmacy will make. There are also vitamin E suppositories. There are a couple different vaginal suppositories that are available. All of those are designed to be generally moisturizing. They're inserted into the vagina at night. You know, sort of as you're going to bed, wear a pad in case there's any leakage, and they'll melt into the tissue. The Vagifem tablet, the estriol suppository, those are the ones that I generally use for women who want that method of improving vaginal health. And so I usually recommend that women do a loading dose of 2 weeks, like nightly for 2 weeks, to use one of those. And then after that, it's sort of as needed, but a maintenance dose of like, 2 to 3 times a week. So it doesn't have to be a whole lot. This, I said, is inserted and left in for 90 days. But it's a very, very low dose of estradiol, but estradiol really cuts to the chase. Estrogen is what the female body wants. And so, the vagina wants it, the bones want it, your skin wants it, your brain wants it, your joints want it, everything wants estradiol. So I like this because it cuts to the chase. But if you can't use that, you have lots and lots of other options. Questions? Any other questions along those lines? I hope this has been helpful. Let me just take a look at I had a whole list of all the things I wanted to talk about. I think I pretty much talked about just about everything. Questions, comments, anything else? Laura from Bellevue, I owe you some follow-up. I hope this has been helpful to you guys. I know we've gone just over an hour. We've talked about hot flashes and ways to manage your hot flashes, night sweats. We've talked about hormone replacement. We've talked a little bit about vaginal health and why. We've talked a little bit about sleep. I have lots of things up my sleeve for sleep. But generally for the menopausal woman, I find that sleep has a lot to do with managing those hot flashes. We talked about birth control during perimenopause. We talked a little bit about testing. I've got a couple of questions. Can you talk a bit about nutrition? Aside from calcium, is there anything else we should concentrate on? Okay, let's see. My mouth is getting really dry. Okay. Thanks, Mandy. Thanks for touching on all of this. I'm going to share this with my needful friends. Well, thank you. And before everybody starts signing off, I want to answer these couple of questions. And I see a couple of people have dropped out already. Some of you are my dear friends. Some of you I've seen in a clinical setting. Please, please, please share my website, share my Facebook page. I'm on Facebook, Instagram, Twitter. I'm doing these crowdcast talks. I'm trying mostly to reach women who have cancer, although this one is obviously for a broader audience. My plan is to develop all of my information that I've collected over the last 20 years regarding natural medicine and cancer and put it on the internet. I am a teacher at heart, and I know that there are so many women around the country who really need good information about how to have an integrative plan for their cancer care. And so I'm trying really hard to do more and more and more of these live crowdcast events and, kind of give you guys some information that can be helpful. And I need help getting the word out. So if you have anybody that you can share these things with, I would appreciate that. So let me answer these last couple questions about nutrition and calcium. So generally regarding nutrition, I recommend that women eat what I call a modified Paleo-Mediterranean diet. Really, the bad actors are carbohydrates. And that's carbohydrates in the form of anything grain, anything overtly sugar, alcohol, and making sure that you're getting enough protein. Most women don't eat enough protein. I don't care how you get the protein, whether it's vegetarian protein or all bacon. I want you to get at least 60 grams of protein a day. If you're doing a lot of physical activity, it can be more than that. But at least 60 grams of protein a day. So many women don't even get that much. And then healthy fats. And I have no problem with butter at all. I'm also a really big fan of intermittent fasting. And so for me, intermittent fasting means 14 to 16 hours of no food. That's generally overnight, either skipping breakfast or skipping dinner, and eating healthy meals within an 8-hour period during the day. I also use fasting pretty extensively with my patients who are undergoing chemotherapy, but that's a whole different talk altogether. Regarding calcium, I think it's important to certainly look at what bone building nutrients you might need. Magnesium would be one, but there are certain nutrients that are used up with stress. And of course, people are under a lot of stress. Magnesium is one. Magnesium goes through the system really quickly. So do B vitamins. So a B complex vitamin is useful. Vitamin C, of course, although the body can only absorb 400 milligrams of vitamin C at any given time. So if you're getting those 1,000 milligram vitamin C pills, you're just peeing 600 milligrams a day out. So smaller doses are better. Let's see what else. Vitamin D, of course, vitamin D. So many people are vitamin D deficient. So get your vitamin D measured. And I generally recommend 5,000 IUs of vitamin D daily. I have no problem recommending that kind of dose for a regular consumption. So I think that pretty much answers a lot of your questions. I know there are a few that I missed because I missed them. Let me see what else here. So at any rate, hopefully this was helpful for everybody. If you have any more questions, feel free to send an email to me at info@laurajamesnd.com. Please share, who I am and what I'm doing with other people that you might think are interested. This talk has been recorded. It will be available for replay in perpetuity. So if there's someone who wants to watch it again, if you want to share this with one of your friends, you can just send them to my website. I have a section called online courses, and this will show up there. So I'm so happy you guys all came, and one of you, I know for sure I have a few follow-up things to get back to. Nice to at least see all your little emojis over there. And, good luck. Menopause is not an easy road, but with all these tools, hopefully you're going to come out on the other side better and feeling good as you go through it. And feel free to reach out to me if you have any more questions. All right. Thanks, folks. Good night.